glad to be having a very what's going to be a very interesting session talking on matters adolescent. So from the topic, we can see that adolescent HIV programming in Kenya, the best practices. And with us, we have a great team of presenters. I'm going to go right ahead and introduce Dr. Immaculate Mutisia, who will be heading the session to give us a presentation. So Dr. Immaculate Mutisia is a public health specialist, pediatric HIV/AIDS treatment and prevention, NCDC Kenya, Division of Global HIV/AIDS and Tuberculosis, with 12 years experience in public health program experience. She holds a master's degree in medicine in pediatrics and child health, in Master of Science in global health and infectious diseases from the University of Edinburgh, Scotland, UK, adolescent health programming from London School of Hygiene, and tropical medicine from London, UK. So Dr. Immaculate, karibu sana, you can go ahead for the session. Thank you.
Thank you so much, Agnes, for that introduction. I will go ahead and start my presentation. And I will be talking about Operation 000, which is an asset-based approach for adolescent programming. We've adopted asset-based approach in HIV programming for adolescents with very good results in Kenya and in other countries. And I would like to share the concepts, and I will have three other panelists just discussing the impact at program level. I have no disclosures to make for this presentation. I will start by just describing the Kenya HIV burden. We have a population of about 47 million, and adolescents 10 to 19 years account for 24% of the burden. The HIV prevalence is about 4.9%. And out of the total burden of people living with HIV, adolescents account for about 10 to 15% of that population. So it's quite a huge burden. And when we look at the Kenya map, we have the highest burden counties in Western Kenya, that is Homa Bay, Siaya, Kisumu, and Migori. Nairobi also sits in as one of the largest high burden counties. And we have other counties that contribute to a large population of PLHIV burden in Kenya, and most of them are PEPFAR supported. And I will just be describing the scope of OTZ implementation in Kenya, specifically talking about where CDC supports. We are currently in 13 counties, and we take care about 60% of adolescents living with HIV in Kenya. I'll start by describing the Kenya's response to adolescent HIV prevention and treatment. And I want to say, as Kenya and as a country, we are privileged to have a very good policy environment. In 2014, we had the first adolescent package of care, also known as APOC, which was developed by the Ministry of Health under the leadership of NASCOP. And we have implemented that over time with good results overall. We have had a lot of strategic information milestones in terms of disaggregating our data for adolescent programming and ensuring that we are able to carve out the adolescent program needs and identify what proportion of our adolescents are living with HIV and what kind of support we need. We have a leadership commitment. And in terms of the adolescent package of care, it takes care of focusing on the healthcare providers and ensuring that they can support adolescent programming. So we have a very conducive policy environment as a country, and that's a privilege. In terms of implementation of the adolescent package of care, which was launched in 2013-2014, what was notable is that following an implementation science assessment that we carried out in 2016-2017, what we noticed that in the sites that we sampled, we had very good results in terms of the quality of care. We had the adolescent package of care implementing sites having better care in terms of high uptake of disclosure, having adolescent specific days, and just improved provider confidence in terms of training. And this is just to say that the package of care was a healthcare worker guide. So it wasn't surprising that when healthcare workers were trained with the adolescent package of care, they went out and set up standards that were, enablers for adolescent programming, specifically ensuring that adolescents are seen on specific days. There's a very structured way of identifying adolescents who need disclosure, etc., etc. But what was notable is that when we compared the adolescent package of care sites and the non-adolescent package of care sites that were implementing were not implementing the adolescent package, what we noticed is that there was no change in overall outcomes for adolescents, specifically in terms of viral suppression. There was no significant difference between the APOC sites and the non-APOC sites. So as a program, we thought about how can we make our programming for adolescents more responsive and in a way that we get the outcomes we want. And one of the aspects that we considered was asset-based approach programming. An asset-based approach programming has been used in various countries. We don't have a lot of local data just to demonstrate how we have, but OTZ comes in as one of the programs that has really emphasized and is really anchored on the tenets of asset-based programming. Most of our public health approaches for adolescents is based on a deficit approach. And this deficit approach is where you program as you respond to a problem. When you are programming for adolescents, you see them as passive recipients of care. But when we look at asset-based programming, we look at adolescents as co-producers, as active participants in their care. And therefore, we involve them in a manner that at the end of the day, we can get the outcome. So when I look at the adolescent package of care, it approached the program from a deficit approach. And there's nothing wrong for having a deficit approach. But the approach was deficit-based and adolescents were passive recipients. And therefore then, we were able to improve a lot of the quality of care aspects, but the outcome piece was left missing. And that is what gave birth to, thinking about getting an asset-based approach, intertwining it with the deficit approach, just combining the two because none of them can exist on its own, and ensuring that we come with a comprehensive package that takes care of both the adolescent, the caregiver, and the healthcare workers. And what do deficit approaches factor? One of the biggest things that an asset-based approach factors is the ability to know that the person who is receiving the recipient of care is a core component of the wider team that is geared towards better outcomes. So in essence, we are saying that as a country, we have a very conducive policy environment. If you are looking at adolescent outcomes, then we have to think of the healthcare worker, the caregiver, but we must look at the adolescent as carrying the bigger pie. Because if we do so, then we focus on them, we encourage them to participate, and by so doing, we can have a comprehensive program that results to outcomes. So basically, when we look at asset-based approach, we look at adolescents not as a problem to be fixed, but as a potential to be nurtured. We look at what are the assets within an adolescent that we can tap into and utilize to make them more in charge of their health, more responsive of their health, participate effectively in their health, and at the end of the day, achieve better outcomes. And that is what gave birth to Operation 000. Operation 000 just means zero missed appointments, zero missed drugs, zero viral load. And there are many other zeros that are anchored on these three. We have zero MTCT, zero stigma, zero TB, zero infections, zero missed school, and you can add as many zeros as you may want. But it is a program that looks at adolescents being aware of their goal. Their goal is to achieve zero viral load. And therefore, then for them to achieve zero viral load, they have to have zero missed appointment. They have to have zero missed medicines. And the OTZ motto is heroes for zeros and zeros for heroes. It takes a hero to be a zero and a hero to be a zero. So basically, the package takes care of the adolescents themselves with very comprehensive treatment literacy, ensuring our adolescents are connected, they are empowered, and they are motivated, as well as actively participating in their health, takes care of the healthcare worker, and we train them using the adolescent package of care. And that's why I said we tie both the asset-based approach plus the deficit approach for us to come with a very comprehensive package. And it takes care of the caregivers. Most of our adolescents spend more time with the caregivers than anybody else. So we cannot leave the caregivers out. And the motivators for Operation 000 Champions is just being a hero of your health, being able to identify with a club, being recognized as somebody who is in charge of their health, and being able to demonstrate good outcomes. So what is OTZ anchored on? One, it is anchored on the adolescent brain. And the way we know the adolescent brain is that as a developing brain, there are few things that adolescents desire. One is identity, desire to be cool. They have a very high learning capacity. Their peer opinion matters to them. They're very energetic and want independence and autonomy. And what OTZ does is take these as assets and form a group with very clear goals. Make them cool by ensuring that they desire to be heroes of their own health. Ensure that there's positive peer pressure and they stay connected with peers who have a positive mindset, who share a goal. And using their energy, they can demonstrate their commitment through song and dance, through acting, leadership, and many other things that they're able to demonstrate. And overall, we ensure that there's adult leadership that is provided by both caregivers, their teachers, their healthcare workers. So it's not an isolated program. It's a program that recognizes that in as much as our adolescents need independence, in as much as they need autonomy, they still need that oversight from caregivers and teachers and healthcare workers. So it's a very comprehensive program that ensures that we take the adolescent brain and utilize the assets that they have to ensure that we get a good treatment outcome. So what are the modules of adolescent? And these are anchored on the previous slide. Just to say that one of the things we really enhance in Operation 000 is ensuring that adolescents recognize they are part of the solution of their health. That if we want to achieve viral suppression in adolescents living with HIV, then they come in as active partakers in that. They are not being told, do this, do that. They're saying, this is what I know, and these are the decisions I will make because this is about my health. We sit with them and develop individualized plans. We don't tell them, take medicine in the morning and evening. We look at their schedule. What time is best for you to take your medication? How can we ensure that it's 12 hourly for those who are taking 12 hourly? But how can we ensure that your time, if you're taking once a day, then you're taking at consistent time every day based on their plan? Those who are in boarding schools, those who are in day schools, we are able to sit. We sit with them and plan. Your current viral load is this. How do we make it a 0? How do we move your current viral suppression to achieve suppression? How can we move your current viral load to achieve viral suppression? So we involve them as co-producers of their health. We give them education on their treatment. We do not go through advanced HIV curriculum. We tell them basics about HIV medication. We tell them about their disease. We empower them that if they can take their medication, if they are able to be in charge of their health, then the outcomes will follow. And then we also talk about positive outlook, ensuring that they know for as long as they're in charge, for as long as they're able to take their medication, then they can live a very fulfilling life without having multiple or recurrent infection, without having to be having hospital admissions, without missing schools. We ensure that they stay connected and they are able to choose peers who influence them positively. And lastly, we enhance their leadership skills at individual level, that they know that I can lead my health. I can be in charge of myself. I can lead others. I am a hero or 0. And that's basically the core component of OTZ, what we train them. And this is really anchored on the adolescent brain and making sure that we keep them connected, but we also utilize their ability to understand issues, utilize their ability to recognize that they can set a goal, utilize their ability to understand that they can work towards a certain goal. And for these cases, the 3 zeros of OTZ plus the many other zeros that are related to OTZ. So what are some of our results? One is the adolescent engagement and the caregiver engagement that we have seen. We are able to have our caregivers engaged. Our adolescents who are viremic, we are able to have them in viremia clinics. We recognize those who are doing well. We have started IGA or income generating activities. And this is just a sharing of how our healthcare workers are proud when their adolescents are suppressed. You can see this is just showing our healthcare worker is so proud that they send out their viral loads and they have come back, and all the age bands, they can say they have a optimal viral suppression, and 100% viral suppression among adolescents is a rare thing. And sometimes when we present this data, our countries really envy our program, and it's something that we have taken to other countries. Looking at active participation of OTZ, one is that we use the talents that adolescents have. So we do not develop, glossy material for adolescents. We do not develop their mottos and their pledge. What we do, we encourage them and they are able to develop their own mottos. This is an OTZ corner in one of our facilities. You can see these are hand-drawn material where they say even, they can show what they understand, their thinking, and how they will be able to achieve their viral suppression. We recognize them with our OTZ passports, watches, and some water bottles. This recognition is part of the package, but is not the core. The core is the intrinsic ability of an adolescent to make an individualized plan and to achieve a good outcome. So this comes as nice to have things that we add on, but basically our adolescents are very engaged and they're able to take charge in some of the activities. When we look at adolescent viral suppression in CDC counties, what we notice is that our overall viral suppression by county in CDC supported sites, we've hit over 90% in majority of our counties. And this is coming from a baseline of 63% in 2017. And what is notable is that it's not easy to just increase viral suppression by a 20% margin. So this is quite commendable. What we noticed is that the absolute number of adolescents who are viremic has substantially come down from 5,000 to below 1,000 in CDC sites, and mortality of adolescents has significantly gone down. So basically just to say that the program has been impactful, and we are making a lot of progress in our sites, with most of our sites implementing OTZ at over 90%. In terms of OTZ scale up beyond Kenya, in 2018, we had a multi-country visit, and we had different countries come to learn. This was a site visit at Mater Hospital, and we were able to learn a lot. And this multidisciplinary team went back to their countries and were able to implement. Nigeria has implemented OTZ in more than 60% of their sites. Ethiopia has piloted in several sites. We have also OTZ adaptations in both Mozambique and Malawi. And we have also had our headquarters team from CDC, DOD, and USAID, supporting OTZ activities. I'd like to highlight Ethiopia's success, and just to say that the OTZ implementation in Ethiopia, they were able to customize it to meet their needs. And I present their OTZ anthem, just showing what they say about OTZ, just crafting the 3 zeros, ensuring that the adolescents understand that they are in charge of their health, they can take responsibility. They have the OTZ register. Currently for us in Kenya, we've already converted the OTZ register into an EMR tool, so we do not need to have the hard copies. And they were able to do their trainings in Ethiopia. We've been able to join their meetings virtually, and they have made very good progress. I present their data of OTZ implementation in 6 pilot sites. And what is notable is that their viral load baseline in 2019 was 77%. And 12 months down the line, they've increased to 95% in 6 sites, which are their pilot sites. They are scaling it up across the country, but it's one country that is proud that they were able to learn about this interesting program of empowering adolescents. So basically to say that structured literacy empowers adolescents to take ownership of their health. And OTZ clubs give adolescents a voice. They are empowered and they are able to do individualized plan that results to overall outcome of their health. So I'd like to acknowledge the Ministry of Health, PEPFAR Kenya, CDC, both in Kenya and Atlanta, our implementing partners, our OTZ champions, who have supported and who have believed in themselves and who have resulted to very good outcomes, because we believe in positive outlook, and we are looking forward to see these young people transform a generation and become responsible caregivers, responsible employers and employees in the near future. Thank you, and over from me.
Thank you very much for that, Dr. Immaculate. It is indeed a very wonderful presentation, and it's always good to hear about all these things that are being done to improve the adolescent HIV care in Kenya. We'll welcome our next presenter. Maybe you can go ahead and welcome the next presenter according to the schedule.
The next presenter is Anthony Kiplagat. And Anthony Kiplagat is the HIV program manager for Nairobi Metropolitan Services. He will be telling us about the burden of adolescent HIV in Nairobi, and he will be telling us how they have implemented strategies to avert mortality and improve outcomes for this population. Thank you.
So thank you, Dr. Immaculate, for the introduction. I hope I'm clear from your end.
Yes,
just confirm.
Yes.
Thank you. So I'll quickly take you through the presentation concerning the HIV status at Nairobi Metropolitan Services, that is within Nairobi County. And looking at our program, where we have the program that is dedicated to the young people, especially the adolescents in Nairobi, our main goal is to reduce the new infection and also improve the treatment outcomes, especially for the adolescents whom we are having within our programs here in Nairobi. But also there are some objectives that we are endeavoring to achieve, and one of them is reducing the new infections, but also improving the case identification and linkage to care, which is critical, especially for the adolescents and their young people up to the age of 24 years, but also increase the ART coverage and achieving the optimal viral suppression. But of importance too is also to improve the continuation of treatment among the adolescents and young people living with HIV. And one of the overall treatment or the program outcome is the optimal viral suppression and also the continuity of care. So just to bring you to up to speed with the HIV situation or the status within Nairobi as per the estimates of 2021, and I'll just be biased to the adolescents and young people, is that our prevalence now as Nairobi stands at 5.1. And usually if you look at the female prevalence is more near double the female one. And as Nairobi, the burden that we are estimated to have of people living with HIV is 165,903. But keenly looking at the young people, adolescents 10 to 19 years, we are estimated to be having around 8,185. And the annual new infection of 433. And probably in the subsequent slide, you'll see the case identification that we are able to achieve as Nairobi over the period. Now, also looking at the young adults, the ages 15 to 24 years, we are estimated to be having around 15,536 people living with HIV. And of the new infections around that is around 1,129, which is also a concern because you can find that the new infection, especially among that age, is higher, and it's contributing to around 39% of the adult new infections in Nairobi. So you may find that the new infection, especially among the adolescents and young persons ages 15 to 24 years, is still a concern for us as Nairobi. And just to mention the MTCT rate, which is also critical to know, that is at now at 8.6. I know that in the year 2020, we were at high of 11.1%, but it have a slight drop, but it's not really, it's important. It's worth mentioning that as Nairobi, we are endeavoring to achieve elimination of mother to child transmission at less than 5%. So this is just an overall 95 strategy. And our achievement is at December 2021. And looking at the numbers that we were given to identify at 165,903, as at December, we had 168,000 people living with HIV, 875, and of which those who were put on treatment were 168,776. And looking, I know as a program, we will appreciate that in the previous year, especially in the better part of 2020, 2021 and this year, we've been having a challenge on viral load services for our clients, but I'm happy to say that we are now resuming slowly because we've started receiving the containers that are used for sample collection and transportation to the reference lab. So we were able to do viral loads for about 156,000 people. And if you look at the viral loads suppression, the uptake viral suppression, this next slide is just to point out on the specific populations that we are discussing and focus just for this discussion will be around the adolescents and the young people. And if you look at the adolescents, the figures that we were given at 10 to 19 years, we are supposed to identify 8,185. So as Nairobi, we've been able to identify 7,321, that is at December. And that is around it. Also, so we do not have adolescents who are not put on treatment. All of them are already on treatment. So those who are on treatment are also 7,321. But looking at the virus uptake and mentioning the challenge that we've been having in the better part of 2021 and this year, is that we only did
Looks like we lost Anthony.
Sorry about that. I'm back. I think I had a problem with the network. Am I now audible?
Yes, you are audible. Put it on slide mode, slideshow.
So thank you. So I was just mentioning that looking at the adolescents, so we are able to do the viral uptake for 50% of them, and the suppression among them was at 91%. So generally, I think we are doing well, and I'll show you the graph showing the trend of viral load for especially this age cohort from 2017 to last year. So also looking at the AYPs 15 to 24 years, our identification, we are supposed to identify 15,000, so, and only we're able to identify as of December 11,758. Clearly there's a gap, and we really need to have strategies to reach out to the difference as given as per our targets. And the beautiful thing is that out of those identified, 100% of them are already on treatment. And just during the course of last year, we were able to do viral load for 43% of them, that is around 5,000. And the virus suppression is also around that figure of 91%. So just to put into perspective for these discussions, yes, we have looking at the objectives. So our priority areas, especially around the objective 1 of reducing the new infection among the young people, is that we've been implementing what we call the risk-based testing. And I know this is something that most of the counties and even facilities are currently doing it, so that we do screen for risks, especially among these age groups, but also test them for HIV. Nairobi is one of the counties that is able to implement the DREAMS component program through the support of the PEFA, but also the OVC. And for us, we are working keenly in terms of integrating, especially to our facilities, so that we're able to maximally get the benefit, especially on the biomedical interventions in terms of prevention, but also linking it to structural and the behavioral component. Also, index client testing is very critical for us, remembering that these adolescents and the young persons come from a family setup, but also they are people who have a relationship, and probably especially for the older the adolescents or even the young persons ages above 20. So it's important to just do the physical tracing and target them for testing, but also capacity building our healthcare teams so that they're able to handle the adolescents and be able to offer the prevention services. And also do what we call the integration of the index client testing, especially in all points of our facilities, and maximally focusing on the MCHs, but also in other service delivery points. Also, we are implementing the HIV self-testing, and we are incorporating, considering that currently we also have commodity challenges, especially around the HIV testing kits. So we've also incorporated the assisted HIV self-testing approach so that we're able to screen our adolescents and test them using the HIV self-testing kits. And for those who are also eligible for testing using the RTK, we also link them to that support, but also having a clear community support. And the objective number 2 is about the improved case identification and linkage to care. And one of the things that we do is also we optimize eligibility screening. And I think I've mentioned about that risk-based testing. And then we also do the regular linkage audits. And this is critical because we really need to ensure that for those clients who have been identified HIV positive newly, we are able to track them and link them to the facility, but also be accountable even for those who are not able to be linked to a facility. Also important is that within our partners that we support, we ensure that we have an updated referral directory so that we are able to have adolescents who are linked beyond the testing facilities or the identifying facilities, be able to refer them accordingly, and also support in terms of the referral. The psychosocial support groups, or the psychosocial support is critical for our adolescents, and also in the aspect of having adequate treatment preparation support, but also ensuring that we offer the treatment literacy sessions for the adolescents so that they're able to understand and really understand what it means to be HIV positive and how best they can live in their new status, but also how best they can also support themselves to ensure that they achieve viral suppression and live a healthy life. Linkage to care navigators is also key. We also have in our facilities the people that we've identified to support in terms of ensuring that the linkage is achieved, especially for those who have faces challenges. Same-day ART initiation is a policy that is adopted within our Kenyan ART guideline, and we also ensure that we implement that to the letter. Of importance is also the adoption of the case managers or the case management. For this case, also in adolescents, we also ensure that we strengthen that so that all our adolescents are benefiting from that kind of support. And also the differentiated service delivery, especially for new clients. And I know this is an area that really, if we implement it fully, then it supports, especially in terms of retention to care, but also improving the quality of care to the young people. On the objective number 3 is also on to increase the ART coverage and achieving the optimal viral suppression, which is critical even for adolescents. And I know some of the areas that we are sometimes struggling is around the viral suppression. So the case management, especially ensuring that these dots, and I know some of the things that we did during the COVID the pandemic, as it really helped us in terms of achieving improving on a case management. And I know probably the previous presenter talked about the issues around the VDots or the video dots or the virtual dots, so that we're able to track our adolescents and ensure that they take their drugs even virtually. Another important thing is about the ART optimization, and I know this is a policy that our current national program is implementing, and I know we started with the adult optimization at around 2019 thereabout, but also recently, last year, Nairobi, we started also optimizing even the pediatrics on who are supposed to be put on BTG10. So it also has an impact in terms of improving on viral suppression and improving on their quality of care. I've mentioned about the differentiated service delivery, psychosocial support, but also integration of OVC program within our facilities. And I know this usually targets ages 0 up to 17 years. So it also captures a critical age of adolescents. Bidirectional referrals is critical so that we're able to ensure that the referral system is responsive to the needs of our young people, so that we do not have gaps or they do not fall in between the cracks. very important, especially for our young people. And I know even next week they will be going back to school. We've also, as Nairobi, started to engage the Ministry of Education and also Teacher Service Commission, so that we strengthen the component of following them, especially in school for those who are in boarding school and have been having issues and struggling with the viral load. So we've trained some school teachers on the HIV care, especially among the students or in the students or among the adolescents in school. And thanks to the support of our implementing partners within Nairobi, I think we've so far trained around 200 teachers. Though the main challenge here is because Nairobi has a lot of schools, especially the public schools of secondary schools, about 200, but also considering the private and the informal school setups. So we have a lot of population to cover. But also doing viral load, I know this is an area that with the normalization of the commodity issues, we will also strengthen and ensure that all our adolescents have viral loads as required. On the last objective of improving the continuation of treatment among the AYPs living with HIV, the issues of appointment and default tracing system is very important for us, ensuring that we have the pre-visit reminders, same day calling for those who fail to attend to their clinic, but also using the innovations. And I know one of the things that even our national program is supporting us is the Ushauri and the Nishauri platform. The other important thing is that we talk about the case management, and we based on the risk and assessment. So we individualize the care for adolescents, young people. And we ensure that we look at that young person as an individual, not as a group or a particular population. So we also endeavor to individualize care, especially for the young people, but also offering the psychosocial support by having the booster adherence and also psychosocial support groups. And I know TZ comes here in hand because it's also offers for that form of psychosocial support, especially for our young people. We've also done periodic patient satisfaction surveys, but also strengthening on the directional referral. I'll quickly move into the case identification just to show you the scenario based on the data and comparing with the positivity. And looking at it, we did it on an annual, looking at 2019, 2020, and 2021. You'll clearly see that the ages 10 to 19, what you can pick from this particular slide is that I know the number of clients being tested overall has been going down, and this is based on the new guidance that we were given about the risk-based testing or the targeted testing, and this is in line also with the current challenges that we are having. So, of importance is that the positivity, especially among the 10 to 19, appears to be less than 1%. But another critical population that we find that we have a bit of increased positivities, especially around the 20 to 24 years. And if you look at across from 2019 at 1.2 has increased to 1.5 and 1.6. So we know that some of the challenges that we've been having is around the commodities, but we've endeavored to ensure that we do not have missed opportunities, especially among the young people. And I said we adopted the use of the HIV self-testing, and so that if we do not have the commodities, our young people are able to also be screened using the HIV self-testing. So some of the challenges that we've been facing is, I think I've talked about from the previous presentation, is the suboptimal identification, especially among the 15 to 24 years. It was around 76, and you're supposed to identify 95% of them. We do have the erratic or inadequate commodity supplies, and these affect across several other counties. The issues of the viral load reagents, the PPT tubes for sample collection and transportation. The issues around the RTKs, I know in this February, we had a challenge with the first response, but things are now coming back to normalcy. The suboptimal eligibility risk screening, we really need to strengthen this. I know we've capacity built some of our HTS providers, but we really need to strengthen this so that we're able to maximally screen for HIV risk, especially among the adolescents and also the young people, and even to the other general population. The inadequate treatment preparation, this is also some of the areas that we have a concern. Nairobi being considered to be a urban city, we have the migration patterns, and I know we have a lot of tertiary institutions within Nairobi, the colleges, the universities, and the young people move in for those opportunities, but also even the households and the other people looking for job opportunities within Nairobi. So this also affects especially the continuity of care among clients within Nairobi. And also disclosure issues. We can agree that stigma still becomes a concern for our young people. The other thing that we've been trying to do is also the interruption in treatment. And I know these was majorly contributed, especially during the COVID time, that people lost opportunities and they had to migrate their families back to the rural settings just to think around that. But we are happy that we've been having a robust default tracking mechanism so that we ensure we follow those young people even to wherever by calling, so and link them to their treatment to their nearest facilities if they are by any chance they're unable to come back to the city. So we've been having partners that we've been working closely within Nairobi. One of the partners is CHEP Connect, that is supported through CDC. We have the Fahari ya Jamii USAID project under the University of Nairobi. We also have another CDC partner called EDAP, the Eastern Binary AIDS Relief Program, that covers the major part of the Eastlands of Nairobi. The Coptic Hospital, the CHAC, that supports our faith-based hospitals, the AIDS Healthcare Foundation, AHF, the Lea Toto program, but currently we are having a discussion of transitioning because the program didn't successfully get the continuation of funds from the USAID. So we're having discussion of transitioning the children and adolescents under this program to the facilities of their choice. But we also have the LVCT Health that is supported by CDC to support our prisons facilities within Nairobi, the 4 prisons facility. So I had mentioned about the viral road trend earlier. So this is just a picture just to show you the trend from 2017, the 5 years trend. And if you clearly look at the 2017-2018, as a county, we've been struggling with the issues of viral road suppression, especially among I know it was worse, especially among the 10 to 19 years, but it's not any better even for 20 to 24 years. But if you look at the graph generally, it has been improving in terms of the trajectory. And so for the 10 to 19 years, the suppression achieved as at last year was around 91%, and the suppression for the 20 to 24 years was at 93%. And if you looked at the initial figure, the overall suppression for our population as of December was at 96%. So we can say that Nairobi, yes, on the aspect of 1990, we've achieved, but now when you look at in relation to 95, we still have some more work to do, is to ensure that all our adolescents are viral suppressions and the young persons are above 95%. So we are happy that, and I think Dr. Immaculate showcased the important how the OTZ has enabled us to make strides in achieving some of these gains. And the other thing is that as Nairobi, we've been adopting the peer-led model so that we also incorporate the young people to take leadership in terms of service provision. So we have the peers that also support us within our facilities to provide a very good environment for young people to be comfortable and seeking services. So the optimization is also a factor that has also enabled us to achieve this viral suppression. Having a potent, safe regimens, ART regimens is also a pointer that has enabled us to achieve on this kind of the positive trend. So just to pause to ourselves, dealing with the young people, and I think Dr. Immaculate talked about their assets, and the young people have that, they value the attention that they are given. And I know if you look at this, when you have a good experience, most of the time people do not really remember about the good experience, but if you just happen to have one bad experience, that is what will overshadow the good experience that we've been offering. So we've been endeavoring really to ensure that we do not have the bad experiencing overriding with the good experience that we've been offering to our young people, but also having the kind of a peer-led models, people who are passionate about the issues of the adolescents and young people, so that we're able to reach out and support them. So in terms of what is next, I know as Nairobi, we endeavor to continually implement and involve the community here. When you talk about the community, is the adolescents and young people driving the agenda so that we're able to achieve the 95-95-95 strategy, but also adopting the high impact interventions. And also as Nairobian, we really value evidence in terms of things that work. These are the things that have shown to work. For us, we are quick to adopt and also learn from it and also even share with others, but also integrating community response and linking the health facility to the community, back to the community. So thank you, and back to you.
Thank you so much, Kiplagat, for that. Dr. Immaculate.
Thank you so much, Kiplagat, for that very eye-opening and very great presentation about adolescent programming in Nairobi County. Like I said, Nairobi County is one of our high burden counties with very high number of new infections, with a very large burden of adolescents living with HIV. And the position the NMS has taken is really going to go a long way in improving outcomes and reducing incident infection among adolescents. I'd like now to welcome Dr. Emma Mumanyi. Dr. Emma Mumanyi is a medical doctor, senior technical advisor with CHEB Connect, which is one of the largest partners supporting Nairobi County, supporting over 70% of the program, the HIV program in Nairobi County. Dr. Emma has been in HIV programming for the last more than 10 years. She's a seasoned clinician, but has also done very impactful work in adolescent programming as well as pediatrics. And she's very, very passionate about children. Karibu, Dr. Emma.
Good afternoon, everyone. Thank you, Immaculate. I think I need to thank the panel, the panelists, and also the participants for being given this opportunity to actually present on the work we are doing with adolescents living with HIV. So CHEB Kenya is a local NGO currently implementing the Connect project that is in Nairobi County, and we do this collaboratively with the Ministry of Health, that is NMS. And sorry, in a nutshell, CHEB currently in Nairobi County, we support 65 facilities. And in these 65 facilities, we have 51 facilities offering PMTCT services. And all our 65 facilities also offer HTS, and 50 facilities offer TB treatment. And we also support 2 methadone clinics for the people who inject drugs, that is at Mathare Teaching and Referral Hospital and Ngara Health Center. And for the key population, that is the female sex workers, MSMs, transgender female, bar hostesses, we support 13 drop-in centers. And we also support 2 drop-in centers that reach out to the people who inject drugs. And our scope also includes a DREAMS program. And in DREAMS program, we actually support 31 wards in Nairobi County. And these 31 wards are feed into 18 supported sites in Nairobi County. So I think a lot has been mentioned by Dr. Immaculate and Kiplagat, and the background has already been mentioned. And for us as a program implementing in Nairobi County, looking at the gaps that we've had in AYP programming, for the adolescents, we noted there was a knowledge gap on HIV/AIDS. There's also a life skill gap, and life skill basically helps our adolescents to navigate through their personal relationships. And also stigma and discrimination is actually a huge challenge among our adolescents, especially our learners living with HIV. Disclosure, post-disclosure support has also been a challenge, and also negative peer pressure. As we all know, adolescence is a stage that comes with a lot of changes and a lot of transition. Also, knowledge gap in the caregivers who are actually supporting our adolescents. And as Dr. Immaculate has mentioned, remember our adolescents spend a lot of time with their caregivers. And also gaps in psychosocial support for learners living with HIV. For the healthcare workers, the gaps were a skill gap in the healthcare workers in supporting adolescents living with HIV, and also just the attitude when it comes to addressing, communicating, dealing with concerns and issues that an adolescent shares with you. So with all these gaps, we realized there was a need to actually come up with strategies and interventions that are inclusive for all the adolescents, so that we can actually ensure optimal uptake to reach most of the adolescents, if not all of them. So as mentioned below, as mentioned previously, Operation 000 basically means 0 missed appointments, 0 missed drugs, 0 viral load. And the whole rationale behind Operation 000 is if our adolescents actually are there and commit to these 3 zeros, then the other zeros follow automatically. And these are the 0 opportunistic infections, 0 mortality, 0 morbidity, 0 stigma and discrimination, 0 interruptions to treatment, and very many other zeros that will be as a result of committing to the first 3 core zeros. And for us, for OTZ clubs, the eligibility criteria to join the OTZ club was you just had to be an adolescent between 10 to 19 years, and you have been fully disclosed to. Irrespective of your viral load, you are eligible to actually join the OTZ club, and enrollment into the OTZ club is actually voluntary. So this was an idea that was presented to the adolescent peers. After being presented to the adolescent peers, cascaded to the other adolescents, and joining OTZ clubs was actually voluntary. Looking at the facilities that we actually support, we had to put structures in place to actually facilitate OTZ rollout. And we borrowed a lot from the current MOH guidelines that we have in place, and also the job aids. So our facilities are actually all of them implementing the adolescent package of care. And we had to have at least 1 staff trained in each facility on APOC, and then have adequate facility-based staff and program to actually support the trainings. And these are our adherence counselors, our clinicians, our peer and our case managers. And then, as I said, the adolescent peers, and then available meeting room space. And it doesn't have to be like a huge space. It just has to be a space that has been converted and is friendly to actually meet adolescents. A trained and experienced counselor working with the adolescents, and then disclosure and post-disclosure support for adolescents living with HIV. When it came to supporting our adolescents for disclosure, which was actually key to ensure that we optimize enrollment into the OTZ club, and it was also key, it is like a baseline to the foundation to actually ensure that they commit to the 3 zeros. We actually implemented and borrowed a lot from the pediatric disclosure algorithm, which is the figure on your left. And for us, when it comes to disclosure, disclosure is done with the caregiver and the child at the center. Disclosure is never done separately. This is a journey that you walk with both the caregiver and the child. It starts at diagnosis. The minute a child is actually diagnosed to be HIV positive, that is the time the process of disclosure is supposed to start. It's supposed to be structured, it's supposed to be planned, and there are other stakeholders who are actually involved in the process of disclosure. Remember, our children are children who are going to grow up, they're going to school, they're interacting with neighbors, they're interacting with other family members, wherever they are coming from. And these are people that have to be considered and to be included in the process of disclosure. And as I've said before, it's not about it's all about the journey and not the destination. As you can see, when you look at a step-by-step guide for the conversations with children, the process actually starts from 0 years and up to 14 years. So you have a 14 years window to actually walk with a patient through the process of disclosure. And it's not the routine that has always been. It's a process, and it's actually not a short process, it's a long process where you work with a patient until full disclosure, and you continue working with them after full disclosure to ensure that they are coping with the new knowledge after disclosure. Looking at the implementation steps in the facilities, upon introducing our OTZ in the facilities, we had brainstorming meetings, and this was to discuss OTZ implementation. And this was done with healthcare workers. We involved the SI team, and for the SI team, they supported us with tools to be used for reporting. We developed reporting tools. We used the OTZ registers. Currently, it has been transitioned into the Kenya EMR. And eventually, what we did was to actually convert all the psychosocial support groups to OTZ clubs. Following the brainstorming sessions and having tools in place, and also rebranding what our psychosocial support groups are, we did sensitization meetings with the TA teams and also the facility staffs. And we engaged not only the healthcare workers, we also engaged the adolescents, and we also engaged their caregivers to actually know what is this OTZ all about, because they are actually key in the success of OTZ. So we introduced the OTZ, the cross-learning, the modules, the facilities, the registers, we trained the peer educators, and we started enlisting all the eligible 10 to 19-year-olds. On enrollment, for enrollment, we ensured that enrollment was being done during the clinic visits, during their psychosocial support groups. Caregivers were sensitized during their caregiver support group and as they were undertaking the caregivers training. And then there was also continuous health talks on OTZ clubs, just to raise awareness and about OTZ clubs, and to just ensure that all the adolescents are aware that this intervention exists for them. And we started the process of enrollment, converted all the psychosocial support groups into OTZ clubs. And we have been enrolling continuously, and we are still enrolling new OTZ members, newly diagnosed adolescents living with HIV as they join the programs. So looking at the package of care, which has been shared before, the package of care for our autism members, we borrow a lot from our MOH guidelines. We've done HTS, and currently we are doing in-case identification apart from index testing, what was previously family testing. We also rolled out social network services for our adolescents. And we borrowed a lot from the successes that we've seen in the key program, in the key population program with SNS, and the youths have actually been, they've actually been very promising. We also offer TPS sessions, treatment literacy classes, and individualized treatment plans for all our adolescents, disclosure, post-disclosure support. We've talked about ART initiation and optimization, the baseline test, case management, differentiated service delivery for our different adolescents, addressing their different issues and their different concerns. So we have holiday clinics, we have weekend clinics, we have flexi hours. Flexi hours can be very early in the morning, late in the evening, whichever the adolescent actually chooses. Cervical cancer screening for the eligible, and currently also rolling out and scaling up HPV vaccination among adolescents living with HIV 10 to 14 years. GBV screening, AIDS assessment, PrEP for the HIV negative partners, and linkage to the OVC program. For the OTZ modules, as mentioned, those are the OTZ modules, the 7 modules, and we also have the other complementary packages, the complementary packages being a school engagements, life skills training, which we have collaborated with the OVC partner, and a source of income for volunteers, that is the OTZ champions, leads, and also currently we have the COVID-19 champions, leads, and COVID-19 mobilizers who are actually mobilizing our PLHIV and our adolescents to actually be vaccinated for COVID-19. So looking at the focus for OTZ, our focus for OTZ has been treatment literacy. We've talked about positive peer pressure, and this positive peer pressure, we are looking at our adolescent peer support, the social groups that they actually participate in. Remember, these are adolescents with a common goal. And also we have now HIV literacy. And for this, we are sharing in-depth knowledge of HIV so that they actually understand what HIV really is. We are also supporting them to cope in school as they transition from the different stages in school. And also we've talked about empowering the adolescents, empowering them to actually take care of their health, empowering the adolescent to know when they should seek health, and to actually engage caregivers, engage the healthcare workers, engage their teachers whenever they need help. And of course, PHDP, focusing on the 4 main goals of PHDP, that is ensuring that adolescents are physically and mentally healthy. We prevent transmission and meaningful involvement of people living with HIV, in this case, the adolescents. Then the other important aspect is after we support the adolescents in the adolescent clinic, we support them to transition smoothly into the adult clinic. And the other added bonuses are career choices, sexual reproductive health, leadership trainings that they can actually used to actually further themselves in the future. When you look at the HRH supporting OTZ implementation, we've talked about adherence counselors, we've talked about clinicians, nurses who are actively involved in supporting our adolescents living with HIV. As a program, what we have done is we also engaged the adolescents themselves. Remember, we said OTZ is an asset-based approach. We are looking at adolescents as an asset. They're not a problem, but they're actually part of the solution for their challenges. And as a program, we've actually engaged adolescent peer educators who are based in the facilities and who support the adolescents in the facility. And for the adolescent peer educators who are in the facility always, their main focus is to ensure that case management is being done for all priority adolescents living with HIV, peer counseling and support, and we manage appointment and defaulter tracing. And for OTZ leads are supporting adolescents living with HIV in sub-counties. The OTZ leads, what they have done is that they're coordinating activities in the sub-counties they have been assigned in the facilities within that sub-county, supporting the OTZ champion, whose function is mainly in the community. And the OTZ champion is to ensure that they facilitate physical and virtual dots for adolescents. So most of our facilities, good retention. Sure things that has happened to adolescents, we have scaled up obviously clinical integration, and the adolescents not only benefit from the clinical team, but they also benefit from the OVC partner implementing in Nairobi County. So looking at the results following OTZ implementation, over the years when we started implementation for OTZ, we started with a baseline viral load suppression of 78%, and that was between October 2016 to September 2017. And we actually started implementation of OTZ in December 2016. And from a baseline of 78%, we actually closed, as at September 2021 last year, our viral load suppression was at 93%. 93% among adolescents 10 to 19 years in 49 facilities at that time. When you look at the OTZ progress from the time of inception, for year one, we had a low uptake of around 13%. And the lessons learned when we started implementing OTZ in year one is that adolescents who are already committing to the 3 zeros were inclined to actually join the OTZ club, unlike adolescents who are not committing to the 3 zeros. Come year 2, year 3, year 4, we really scaled up and we facilitated facilities and targeted all adolescents irrespective of their viral load suppression. And in year 5, we were able to see to close with a viral load suppression of 93% among our adolescents. And currently, as at end of December 2021, our viral load suppression among OTZ members was 95%. To ensure that OTZ implementation and rollout was a success, we've collaborated with different partners, NMS and Ministry of Health providing technical oversight on adolescents living with HIV programming in Nairobi County, Ministry of Education and Teacher Service Commission. What we have done is we trained TOTs on Teachers Guide on HIV, and we did step-down training reaching over 100 teachers. We've also partnered with World Vision Kenya, who is implementing OVC program in Nairobi County, and also other CDC supported implementing partners. And I'll mention CHS, and we collaborated with CHS on the rollout of the Mime Confirm video app Dotsa. And this is an application, a phone application that was used to actually do video directly observed therapy for the adolescents who are actually viremic and ensuring that they actually swallow their drugs every day. Looking at our VC clinical integration, when you look at the clinical integration for VC, the objectives are aligned with our objectives. That is identification, ensuring all our children are retained, after being retained, they are actually virally suppressed. And when you look at our interactions with the OVC program, we've been able to optimize referrals for the HIV-exposed infants for PCR, trace children from index clans who tested positive, trace missed appointments, refer our pregnant women for HTS, support OTZ plus activities. And for this one, they've not only done for the adolescents, they've also done for the pregnant and breastfeeding adolescents and young women, community ART dispensing, and also DOTS. And this DOTS is for the unstable patients, for the unstable caregivers, and the unstable children. And they've also supported open days and activities for the OTZ and caregivers. In addition to just the support that they have given us in terms of ensuring that we support our adolescents optimally, our OVC partners have also have packages for our caregivers, things like positive parenting sessions that are done in the community. We have our adolescents who are actually given materials to actually enhance appearance, like watches, pill boxes. We have adolescents who are being trained on income generating activities and also caregivers. So the beneficiaries for the OVC are not just our adolescents living with HIV, but also the caregivers who are actually supporting them to ensure that we actually achieve our goals. With the successful OVC clinical integration, we have seen the OVC uptake in the program actually increased from a low of 11%, that was FY20 Q1, to 70% as at end of December 2021. The picture on the side is just one of the activities that the OVC partner has been able to support our facilities to do. That is an OTZ open day. And one of the things we talked about is empowerment and ensuring that adolescents are in charge of their own activities. This is an activity that was that is peer-led, that the adolescent is the one who reached out to the OVC partner together with their facility staff, and they organized an OTZ open day, and they just gave feedback that they actually had the OTZ funding. We also have other successes. Looking at our facilities individually, we've seen an improvement in viral load suppression. Looking at the 0 to 19, especially in one of our facilities, currently they're at around 93%. And also looking at our resuppression rates for our 10 to 14 years and 15 to 19 years, especially the 15 to 19 years, our resuppression rate actually went up from 70% to 92%. The image on your right side is just a way of us rewarding facilities that have actually shown marked improvement in the delivery of their services and have actually demonstrated with positive outcomes. And for us, what we have done is that OTZ is not a standalone intervention. We have institutionalized CQI, which is also being done collaboratively with OTZ. And with this, we have seen an improvement in most of our indicators in the facilities. The adolescents who've actually been OTZ members are also awarded certificates. And these certificates are just supposed to actually congratulate them for being role models to their peers and being change agents, and also a source of positive peer pressure to other adolescents. We've also collaborated, apart from just with NMS, in the OTZ activities to support adolescents living with HIV. We've had collaborations with friends to adolescents, that's what we call them, to encourage them in their journey of living positively. We've also had collaborations with successful PLHIVs who have lived positively with HIV, just to present to them a picture of success from which they can actually draw inspiration from. We've also engaged adolescents in their spaces. These are the digital platforms. And from these spaces, we use feedback from adolescents to inform the interventions that will work for them, interventions that they have actually suggested. And we work with them to actually to ensure successful rollout and successful implementation. When you talk about innovations, we've had adolescents who've come up with different innovations in their different facilities to support them. We have kitchen gardens that have been set up as IGAs to generate revenue for OTZ activities. And for the revenues from these facilities has been used to buy watches to enhance appearance, and also participate in interfacility OTZ activities. In the most recent OTZ Fund Day, we were able to reach an estimated 700 adolescents. And these are adolescents who will take back the message to the facilities on what OTZ is all about. We've also collaborated with healthcare workers, with NMS to actually train healthcare workers on adolescent youth-friendly and responsive services. The challenges we've had in the implementation of OTZ, we have a special population among the adolescents living with HIV. These are the key population. And the challenge we've had with key population is that we have adolescents who are key population, but they're not in the drop-in centers. And they're part of the adolescents living with HIV in our general population sites, and they have not disclosed their KP status. And also linkage of all negative adolescents to KP to DREAMS programs. For Ministry of Education engagement, our mitigation efforts where we trained the 25 TOTs, we did step down trainings, and currently we are planning to meet with the head teachers who will be used as facilitators to support the trained teachers to actually support our learners living with HIV. Our next steps are to strengthen our OVC OTZ integration and scale up, strengthen our data collection, and we were looking at our adolescent girls living and young women, viral load suppression, retention among our OTZ members, and also packaging, having a package for key populations, adolescents living with HIV within the OTZ package. I'd like to acknowledge NMS, CDC, World Vision Kenya, CM Kenya, UMB, our facility staff, and our adolescents living with HIV together with their caregivers in facilitating a successful rollout and implementation of CDC. And just a disclaimer is that all the pictures and videos that have been used in the presentations have been shared with the consent from caregivers and assent from the older adolescents. So after the presentation, I think we had a short video around, we had 2 videos around 3 minutes each. And these are just basically our heroes' voices. That is what we call our OTZ members. They are heroes. And we'd like you to see their stories and just hear what they're actually doing and the experiences they have gone through as OTZ heroes. I hope that you're able to hear that.
Yes, we can hear.
Okay, okay. Oh boy. Okay then.
Nilikuwa nakaa na baba. Sasa nile tuko Nairobi mimi na yeye, mama kwa ushago. Sasa hiyo time ya kwenda ushago ndio ugonjwa kanisikia huko. Kaanza kunipiga kaniweka chini. Ndio nikaletwa huko nilikuwa class 4. Emotional nilikuwa nasikia nikaa na kwa discriminated na hao wengine. Juu tuko watu watatu. Sasa nilikuwa na feel as in discriminated from them. Juu unapata sometimes wewe peke yako ndio wewe ni mgonjwa na unataka attend shule. Hiyo ugonjwa imekupiga kukuweka chini. Unashangaa mbona wengine wako na ugonjwa tu ni mimi peke yangu. Sasa emotional nilikuwa as in sad tu. Na physical nilikuwa nasikia tu nikaa niende tu kwa river nijitupe hapo niishi hapo kabisa. Nikiwa home nilikuwa nasaidiwa kumeza. Sasa kwa boarding hapa ndo sasa nimepata na mimi shida kumeza. Nilikuwa form 1. Unaweza pata unakula saa 6 na dawa unafumza saa 3. Ukienda kuambia principal unatumia dawa, atasema unataka special attention. Matron alikuwa at least ananielewa. Anaweza sema kwa unatumia dawa, unaweza leta nikuweke, utakuwa unakujia. Support group ilikuja kanisaidia juu sana nilikuwa naona si mimi peke yangu, kuna wengine. Kila mtu anakuja na challenges zake, solution inatoka hapo. So unapata solution ikitoka unakumbuka. Pia mimi nilikuwa na hiki kitu unasema, unapata ule mwingine pia alikuwa anaona akapata solution anakuambia. Sasa mnasaidiana tu. Unapata at the end of the day umetoka na kitu kwa kitu. Hujatoka bure. Kueleza tu watu mtu asikudiscriminate ati uko na ukimwi, uko na cancer, utatuambukiza ukikaa na sisi. Wakikwambia hivyo na walengo, unakaa chini kuna kana watu wenye unaweza kaa nao, wakikulenga sawa, si hao peke yao ndo marafiki.
I was preparing to go to school. Then something happened. I started falling. Now, after that, my aunt took me to the hospital. I was told I had a stroke. A nurse came. He told me that I had HIV. I thought I am going to die. So I asked that nurse, when will I die? When I first came in here, I saw my age mates, and I realized that I was not the only one. Yeah, I saw even other people, not per se a stroke, but in HIV. I saw my peers smiling, dancing, and talking with each other. So that gave me a sense of a community. If you don't have that good support system, even a nail prick can make you go and try to do something bad. Talking to each other, not counseling, not anything, but just talking to somebody who has a clear idea of your situation, your status, or the way you take medicine is very important to the well-being of a person.
And with that, I come to the end of my presentation. And I think from the videos, what we are trying to demonstrate is that adolescents can actually take care of themselves. They can actually take control of their own health. They can actually have develop interventions and strategies that are for them, by them, to actually support them. And it is just not, it's not a fallacy, it's actually a reality. Thank you for listening to me. I hand it over to Immaculate.
Thank you so much, Dr. Momanyi, Emma, for that sharing. It was quite informative. We have learned a lot, and just demonstrating that adolescents can indeed be heroes of their health. At this point, I'd like to introduce our very own Damaris Nyamweya, the OTZ president for Kenya. Damaris is qualified counselor. She has a diploma in counseling psychology. She works with CF Connect, supporting adolescents in Kenyatta National Hospital. And beyond that, Damaris has moved around Kenya with our colleagues to transform the mindset of adolescents, that they can be the change they want to see. They can be heroes of their health. And she has transformed not only adolescents in Kenya. In 2019, we were privileged to have Damaris speak to adolescents in ICASA, and she has continued to move mountains. Karibu sana Damaris, and tell us your OTZ experiences and what you see for the future of OTZ.
Thank you very much, Dr. Immaculate. Good afternoon, everyone. I hope you can hear me.
Yes, we can.
Thank you very much. My name is Damaris Nyamweya, as Dr. Immaculate has said. I am the president of Operation 000, an adolescent and youth initiative geared towards viral suppression. I'll just give you a short history of where OTZ started and where we are seeing it heading to the future. OTZ was founded in 2016 with only 15 adolescents and young people being recruited. It was an idea to help solve the overwhelming high rates of mortality and morbidity among adolescents and young people living with HIV. With only 15 members then, not everyone had the faith that we would achieve the excellent viral suppression rates that have been projected by my fellow colleagues. And from 15 members to having recruited adolescents and young people, not only nationally, but internationally. We have both WhatsApp and Telegram groups that we use to communicate and keep in touch as OTZ champions in order to support each other and walk through this journey together. Why OTZ? We started OTZ because we were concerned of the high morbidity and mortality rates among adolescents and young people, especially in Kenyatta National Hospital back in 2016. Adolescents and young people coming to the clinic in wheelchairs and their health deteriorating was a big problem to us. The high viral load graphs among people living with adolescents and young people living with HIV, and the frequent questions from our healthcare providers asking us, why are your adolescents failing, was really a bother to us. And that is why we opted to start Operation 000, a club that will motivate them and give them hope and courage to accept their status and take their treatment, not because it is a burden to them, but this is because they are choosing to become heroes of their own health. I know most of you are asking yourself how I became the president. This took place in 2018. We had an election in NASCOP where I was elected as the president of OTZ. I have a deputy president, his name is Paul Gesa, and we have our own cabinet consisting of OTZ Secretary General, the Deputy Secretary General, OTZ Ambassador, OTZ governors. These are governors from each and every county. As we said, OTZ has been cascaded to different counties in Kenya. We have now the champions and the OTZ heroes who are the OTZ members. All cabinet members in OTZ work voluntarily. No one is being paid to become a leader and support the adolescents. We are all doing it out of our hearts because we are passionate of what we do, and OTZ is us. We are the champions, and we need to spread the gospel and support our fellow members. And the OTZ champion cabinet was also chosen in 2018. And at the facility levels, we encourage and support that each and every facility come up with their own OTZ leads, consisting of maybe the OTZ president or the OTZ lead as per the facility, who will now work hand in hand with the OTZ governors. To tell you a short story of what OTZ means to the adolescents and young people, I'll read a poem by one of the OTZ champions. A shadow cast on you is a reflection of the real you. Words that I came to clearly understand once I joined the OTZ club, and more so with a suppressed viral load. I came to understand no sky lacks stars, and everything happens for a reason. No man can cheat luck, and Lady Luck knocks only once. I accepted myself through the operation that was tripled to 0, and that is how a hero was born, not by birth, not through genes, but through the word that I accepted to follow, OTZ. OTZ has created a lot of job opportunities as it has been displayed by my fellow panelists who have presented. Lives for young people, young champions have been transformed. OTZ has given adolescents and young people courage to openly talk about their status, to support their fellow peers through song, dance, and poetry, like what has just been presented. OTZ has transformed the face of AYP health outcomes. OTZ has brought out champions who are sitting in strategic meetings, developing and coming up with ideas and innovations in the HIV care and treatment. But most importantly, OTZ champions have chosen to take charge of their own health, to be heroes and heroes of their own health. As OTZ champions, we would like to thank CDC and CHEB Kenya for the wonderful support in making sure that OTZ is a success. We would like to thank KNH for organizing this webinar. And most importantly, we thank the OTZ champions who have chosen to commit to take charge of their own health and be heroes. As we say, Operation 000, send your hero. Back to you, Dr. Immaculate.
Thank you so much, Damaris. That is so powerful. You actually confirmed to us the impact of positive peer pressure and how adolescents can take charge. Indeed, heroes for zeros. Thank you so much. I'd like to hand it back to Agnes.
Thank you very much. Indeed, we cannot add more. That has been a very, very informative session. And thanks our participants too for staying with us till now. Now we've had a very informative session, starting giving us the overview and telling us about how the youth are supposed to be engaged in these activities and in our programs, and we really appreciate that. Dr. Emma Momanyi from CF Connect, all the implementation work that you've done, it's really commendable. We have we have Kiplagat Anthony from Nairobi County, and all the activities that you've been doing in the Nairobi County. It was really a pleasure listening to that. And our very own Damaris Nyamoya, just championing the OTZ talk. So for now, we have very few questions here. And maybe we'll start off with the two questions actually that Kiplagat you're answering. You can go ahead and just answer them live. Somebody asking about the MTCT in Nairobi. You can just go ahead and answer that live, Kiplagat. Thanks.
So thank you for that questions, and I'll answer about the MTCT rate. If you look at the current estimates nationally, our estimates for the national is at around 9.7. So if we compare Nairobi's and the national, we consider ourselves to be among the lowest because we have regions that have the highest MTCT rates of up to, like Mombasa, they're having a high of 11. And even other regions that like the Northeast and the Manderas have the highest of around 27, the Garissa, the Mandera and the Wajir, and even the Garissa. So I know PMTCT or the MTCT has been a challenge for us as a country, and as a country we've committed to ourselves to the 2024 achievements of the national mile so that we're able to eliminate the mother-to-child transmission. But I'll speak just for Nairobi, is that yeah, Nairobi is one of the urban settings, so we have population migrations that people perceive it is safe to come to Nairobi, especially when they have pregnancy and when they deliver. But once they deliver, they prefer going back to the rural homes. And at times, if we do not have robust defaulter tracking mechanisms, especially for our mothers, then we may end up losing them. We also have the issues of late startment of ANC clinics. We know that most of our mothers prefer to come to the clinic, especially past the first trimester. And one of the successes that we want to achieve the MTCT elimination is that we have to have timely identification and initiation of treatment. We have also have the issues of stigma and discrimination. Most mothers at times fear to come out to be tested and even disclosing their status, and because they'll either suffer the form of gender-based violence, either physical or even emotional, once their partner discovers that they're HIV positive. So they have a lot of reasons why, but Nairobi is not in isolation. If the other regions of the counties are able to achieve much improvement in terms of MTCT rate reduction, then also Nairobi will be able to achieve. I'm also seeing a question from talking about the issues of, is COVID vaccine integrated in, yes, we are currently as Nairobi, HIV, people living with HIV are among the people whom we target for COVID vaccine integration. And even working closely, I'll give an example of CF Connect, where we've been able to map out our CCCs and even identify the teams that will support our clients and for vaccination. So yes, we've integrated COVID-19 into our CCCs, and we are targeting as per the national guidance of whom they're supposed to receive the COVID vaccination. I do not know if there's any other. I'm seeing David. So David, remember that it's about the client's preference. So when you're talking about the delayed first ANC clinics, you find that most of the mothers will come, especially past the first 3 months. And so it's not really a new thing. I think it's something that has been happening across the country, but as Nairobi Metropolitan Services, we are now we have strengthened the issues of community PMTCT, taking the Mentor Mothers program support from the facility to the community and working closely with our community health strategy, structures so that we're able to identify mothers early and link them to or refer them to our facilities for them to start the ANC services early. So one of the things that we've tried to work closely and even with CHEB is about the initiation of the community PMTCT so that the mothers are reached out and also linked to the facility at the earliest opportunity. So thank you, and back to you.
Yeah, thank you. Thank you so much for those responses. We're now coming to the end. So as we do our final comments, I think I'll hand over to Dr. Momanyi. You can answer the question on the mental health question asked as you do your final comments. Then you'll go to Damaris and Dr. Immaculate. Over to you.
This is Anzala. May I say something before Emma comes up?
Yes, sure, Prof. Go ahead.
Yeah, I think for me, this is Anzala from Kavi at the University of Nairobi. I'd like just to really thank Immaculate, Anthony, Emma, and Demaris for the great work. For us here at Kavi, we are struggling to get an HIV vaccine, but what I can see is that work that is now being done with all these colleagues to keep the HIV population well taken care of and ensuring that they live normal lives is really beyond what I really expected. So mine is actually to thank all of you and tell you, go ahead, keep us posted. But at the same time, Emma, Demaris, Anthony, and Immaculate, if there is any collaboration you'd like us to join in and do, our door is open and you know exactly where to find us. Thank you very much.
Good afternoon again. So the question I have seen for me is, what is our experience with implementing SNS in OTZ? When it comes to adolescents living with HIV, we realize we have adolescents living with HIV within our cohort who are actually sexually active, who have partners that are not in our facility and have not been tested. With the rollout of index testing, our initial thought was that index testing will be a success and we'll be able to get these partners on board and actually ensure that they're actually tested. But following rollout of index testing among adolescents living with HIV, we found it was actually a challenge because of the high index of stigma and discrimination among this population. They were not able to share their partners with us. Remember, these are the partners are either their peers, their partners are also people older than them. And because of this, they were not able to share with us. But what we did is that we borrowed the successes that SNS had in the key population program, and we decided to integrate SNS with index testing. So for the one adolescent who we are offering index testing to, we are also offering SNS for them. And the rationale behind SNS is that for lack of better words, is that birds of a feather flock together. So if you have an adolescent who's at a high risk of acquiring HIV or transmitting HIV, there's a possibility that this is also an adolescent. This is an adolescent who's also hanging out with people, or the people within their networks are also at risk of acquiring, or if they have positive ones within their networks, they're also at a risk of actually transmitting the virus. And so what we did is that when we rolled out SNS, we started with the peers who are within our facilities. These are our OTZ champions, our OTZ leads, our adolescent key educators, and they shared their networks with us. And we also targeted adolescents who've just come to the facilities for testing who are actually high risk. And we targeted their networks. And we also targeted newly identified adolescents who have been enrolled into OTZ to actually share their networks with us. And with this, we have seen yields of at least 2 to 3% among our adolescents. And we believe that should we scale this up and target all eligible adolescents, we are actually in a position to actually identify more adolescents living with HIV, link them to treatment, and actually prevent transmission of the virus. Thank you.
Thank you for that, and thanks for those comments. And if there's need for collaboration, and we're happy to do that. Damaris, you can give us your last comments. Just highlight on how guys will be able to join the OTZ as you give us your last comments.
Thank you very much. And I will just echo what Dr. Immaculate said. Let's look at adolescents as the solution and not the problem, because we know that we are the generation and the next presidents, pilots, engineers for the next future. And to programs that have not yet implemented OTZ, I will urge you to please do so, as we have seen from the presentation that OTZ works, and it really works, and it is going to be a very important club for your adolescents, and it will improve the viral suppression rates among your adolescents. Thank you.
Thank you, Dr. Immaculate.
Thank you so much. I'd like to start by thanking the KNH research team for giving us an opportunity to share, and just appreciate all the presenters and all the participants. In the house, I can see we have Dr. Mark Guterres, who is the CDC country director. And I wanted to see if Dr. Mark, you can just say hello. Okay, probably just to also just echo my colleagues that it's been a long journey. We appreciate the invite from Prof to collaborate, and indeed we'll be coming at your doors just to see how we can work together. But it's OTZ is a game changer. It has transformed lives of many adolescents, and it has a very strong sustainability approach. Our clubs are facility-based. Our activities are facility-based. They are linked to clinic appointments. And what the biggest strength in OTZ is that it taps into the intrinsic aspect of an adolescent. And therefore then the sustainability agenda then becomes very, very feasible, because that adolescent will become a young and responsible adult who will turn out to be a young mother or a young father who will continue protecting HIV transmission while at the same time living a healthy and fulfilled life. Thank you so much, and that's over from me.
Thank you so much. Thanks our participants. We welcome you for also the upcoming sessions. Actually, this HIV series will have a series on adolescents. We'll have a second session just talking on OTZ plus in the week after next week, and we'll keep you informed on when we'll have that, and also have a session just looking at the pediatric care and pediatric HIV series. So we'll welcome you for those sessions, and we just really appreciate your contribution and just being here with us. So thank you all. Do have a lovely afternoon. Goodbye.